the opportunity to talk about new applications of hyaluronan in the nasal and sinus field. We know that sinusitis is a social problem. Its prevalence is increasing, especially in the last years and in the metropolitan areas. So it causes high social cost. We usually classify chronic rhinosinusitis in the hyperplastic one and in the polypoid one. This polypoid form can be an evolution of the hyperplastic one. According to recent classification, chronic rhinosinusitis typically lasts more than 3 months, and the patient in this period shows the classical clinical picture of nasal and sinus blockage. Besides, we must have seeing at CT scan or at endoscopic examination. There is also the recurrent acute rhinosinusitis, in which the patient has 4 or more episodes per year of acute bacterial rhinosinusitis. It's possible to perform primary prevention to reduce the risk of initial rhinosinusitis episodes. It's a good practice to a good hand hygiene, to avoid exposition to tobacco smoke, and eventually to correct sinusal abnormalities, and we suggest also to correct several systemic disorders can facilitate the development of chronic sinusitis. There is also secondary prevention to minimize symptoms and exacerbations. The most commonly treatment used were oral antibiotics, nasal topical systemic steroid, nasal irrigation, but there is limited evidence for the use of these drugs, especially we don't know very well the duration of the treatment, the kind of medications, and the kind of administration. Otherwise, we know that fast surgery is associated to high success rate. In the last year, in my university, we are studying the hyaluronan acid on the respiratory tract, and today hyaluronan is widely used in many branches of medicine, but not only in aesthetic medicine, but also in the treatment of the chronic inflammatory process. We know that hyaluronan is normally present on the respiratory surface, and it promotes tissue healing, cell proliferation, stimulates ciliary motility, and interferes on bacterial adhesion and bacterial biofilm production. In this slide, we would like to resume the main characteristics of hyaluronan, its bacteriostatic effect, viscoelastic properties, anti-inflammatory and anti-edematous properties, and so it could be a candidate to relieve symptoms in that patient. So the aim of the study was to evaluate the role of hyaluronan in the secondary prevention of in patients affected by chronic rhinosinusitis, compared with simple nasal washes with saline solution. So we had two groups. One group treated by hyaluronan, and the other group, the control group, treated with saline solution. And all patients received the substance by rhino wash, that is an Italian nasal doses, and later we can see the therapeutic schedule. About 40 of our patients are allergic, and this is the schedule. So the hyaluronan group received for the first 10 days amount for 3 months consecutive hyaluronan, 2 cc of solution of hyaluronan plus 3 cc of saline solution, and in the rest of the month we receive only 5 cc of saline solution twice a day. The control group received saline solution twice a day, 5 cc, so these nasal doses. We evaluate the major and minor symptoms, and we evaluate also the endoscopic picture of this patient, in particular the middle turbinate edema and nasal secretion. We can see that the patient treated with hyaluronan showed a significant improvement of their symptoms, unlike the saline group, the control group. Also, the endoscopic picture was significantly better in the hyaluronan group versus saline group. So we can conclude that hyaluronan could be very useful in the treatment of chronic rhinosinusitis, both in patients not underwent to fast surgery and in patients after functional surgery. We would like to do a special focus on devices for topical therapy for sinus and nasal cavity. We know that the final common pathway for mucociliary drainage is represented by osteometal unit, and so this osteometal unit must be the target of medical and surgical treatment. So we have a lot of medical devices, but according to our recent studies, the top for nebulization in these cases, in cases of patients affected by sinusitis, is represented by a nebulizer that nebulizes particles between 10 and 20 micron. We know that like spray, the nebulization, if we have nebulization between 10 and 20 micron, it's possible to reach the inner and the upper parts of nasal cavities. This is an experimental in which we compared the distribution of blue methylene in nasal cavity. On the left side we can see the distribution of spray, and on the left side the distribution of nebulize, specific Italian nebulize, and The same we can see on the cadaveric specimen. So the future is is this Swiss spray-sol upper way specific irrigator that nebulizes between 10 and 20 micron, and with this device it's possible to reach osteometal complex. If there is a greater amount of substance in the osteometal unit, it's possible that during expiration this drug can enter into the maxillary sinus and ethmoid sinus. Unlike the other nebulized specific for upper airway, the Swiss is faster, high compliance, pocket, low cost, and monopatient, and there is no problem of sterilization. This scientific study was published on the American Journal of Rhinology, and thank you again, the organization and my colleagues, and enjoy your congress.
Thank you so much for a wonderful presentation. Any questions? No questions? If I may ask you, I hope I didn't miss, you said you were only applying this as nebulization?
Yes. Non-nasal spray, because we would like to reach osteometal complex. We know that with spray, the spray is wonderful for the head of the inferior tubular and for the floor of nasal cavity. But in patients affected by rhinosinusitis, is mandatory to reach osteometal complex. And so with this, with sways in the future, with nasal dodges in the present, it's possible to reach the osteometal complex.
I'd like to say something. Thank you very much for a good presentation. I appreciate. Why did I come here? Because I had some reservation, and I would like to say a few things. Fungal sinusitis, chronic sinusitis, no matter whatever you do, it has some problems. Complication, whether as sir you said that HIV complication, whether you say as fungal sinusitis, it lands into complication. It doesn't kill. There is no mortality. It's a severe morbidity. Number one thing. Another important point that I would like to mention is that look, osteometal complex is a complex issue, and it has to be dealt with the way it has to be dealt with, and the only way is the endoscopic sinusitis, functional endoscopic sinusitis, and that is the only way where you can reach there. You cannot by spraying reach and open the because it's a junction from where your frontal sinus comes from the anterior posterior ethmoidal sinus, the maxillary sinus, so all open up there, right? And it is a big junction. It doesn't open up with spray, I'm afraid. So that is very, very important. The endoscope was used only because they had found this pathway. And Wiesenklender in Austria was the one who invented this, who found out. And afterwards, Stemberger and David Kennedy and a lot of people came, and they worked very hard on osteometal complex. And they investigated, found out that this is the junction. If they open up this area, they can open up all the sinuses. So that is very, very important, I would like to say. Thank you very much.